Welcome to Nursing 103, Chapter 86, Respiratory Disorders, remake, because somehow, somewhere, the video that I uploaded last week has gone poof. So, love computers. Let's give this a start, shall we? Oop. Share screen. Okay, here we go. Respiratory disorders. Here we start with another one of those universal nursing things, ABCs. If you don't have A, B, and C don't matter. All right, ABC, airway, breathing, circulation. If you don't have an airway, you can't breathe, and circulation becomes kind of a moot point. If you have an airway but you can't breathe, again, circulation becomes kind of a moot point. You got to have A to continue B and C for very long. So if you don't have A, B and C don't matter. Respiratory system, all right? Respiration, got to have a patent airway, right? You're bringing oxygen into the lungs, exchanging it for oxygen and carbon, exchanging the oxygen and carbon dioxide, getting rid of the carbon dioxide, and sending on the oxygen to the cells in the bloodstream. Got to have an airway. Now, what's the big deal about carbon dioxide? If I can't get rid of it, what happens? Here's another one of those things that you will track throughout this program. Write this down, CO2 equals acid. If you keep building up CO2 in your bloodstream, CO2, when it dissolves in water, becomes carbonic acid. So you've got to be able to not only bring the oxygen in, but get rid of the CO2. This will play in later when we start talking about complications of respiratory rate. So we got the upper and lower respiratory tract. When you put it into the or through the lens of our current COVID-19, upper respiratory tract. When you think of a disorder there, allergies, the common cold. Lower respiratory tract, you'd be looking more towards asthma, pneumonia, right? As far as the folks that work with the respiratory system, besides nurses, I'm going to bring you down to respiratory therapists. If you have the good luck to work with a respiratory therapist, silent, hold on. If you have the good luck to work with an excellent respiratory therapist, then life is grand. Hang on just a second. Well, it seems that the administrator's job is never done, so let's go back to where we were at. Okay, back here to, let's try that again. You ever have one of those days? Okay, here we go. No, this one. There we are. Ha ha ha. So back to where I was at. If you ever have the opportunity to work with a respiratory therapist, treat them well. As nurses, we're kind of multi-tools. We know a lot of things pretty well. Your respiratory therapist is an expert in patients' respiratory conditions. They may not know how to put in an IV. They may not know how to do an INO, but as far as respiratory goes, these are the super duper pros. And as I already mentioned, if you don't have A, B and C don't matter. So shout out to our RT people because they are worth their weight in platinum. Oh, Are you kidding me? Having a computer day here. Slide. Here we go. Now it works. So lab tests. When we're looking at investigating respiratory disorders. Sputum specimen. Now there's a difference between your sputum specimen and just spitting in a cup. Okay. And it's one that your patients don't get. A sputum specimen needs to be, well, pretty much all snot. You will often get lab or specimens returned from lab because there's too much saliva. Reason being for this is the bacteria in the mouth may be markedly different, hopefully are markedly different than the bacteria in the lungs. What we'd be looking for in the sputum specimen is what's growing in the lungs. Lavage specimens done their washout, and throat cultures. Well, anybody who has been tested for COVID, well, I won't say anybody, most who have been tested for COVID-19 have either had a nasal swab or a throat culture. And then blood gas determinations. ABGs, we're going to go into these much heavier in second term. The ABG is a wonderful lab that will tell you a whole lot about, well, really about what's going on inside the body. So how much oxygen is actually riding around, and this is a different measurement than the pulse oximeter, right? This is taken directly from arterial blood. The pressure of carbon dioxide, how much CO2 is in the bloodstream, and what the pH is. Here's another one of those universal truths. You will, hear this more than once, especially if you're taking my classes. Life as we know it exists in a fairly narrow range of temperature and pH. Temperature gets too high or gets too low. Well, let's take temperature gets too high and the proteins that make up living beings denature, they change shape. The enzymes that catalyze the reactions that support life denature, change shape, no longer work. Temperature gets too low, processes slow way down. Right? pH, it is again dealing with we run. So from a, okay, here we go. I've got this set up not as a mirror, so it confuses my brain sometimes. So we have here, we have a pH of 0. Here we have a pH of 14. That's our scale. Okay. 14 is not acid. 14 is basic. 0 is the acid side. We run, you would think, okay, well, people, we'd be right there in the middle, right? We'd be at a pH of 7. Actually, we run slightly alkaline, pH of 7.35 to 7.45 is our normal range. So really very narrow range of pH and a fairly narrow range of temperature. X-rays, good old chest X-ray. Take a picture, see what's growing. You can now, X-rays are great for seeing dense structures. They may not show you the softer structures, but dense structures like bone or collections of fluid and mucus that are denser than the surrounding tissue. Right? CT scan, lung scans, lung perfusion scans. These are different in that you're actually looking at the gas exchange that is happening. And last but not least, a pulmonary angiography. Okay, so a surgery is a surgery is a surgery. An angio is an angio is an angio. The difference is location. So a pulmonary angiography, we are looking at the vasculature in the lungs. The same basic patient safety pieces apply. And the big one there is knowing the patient's allergies. Because these angios very often use a radiopaque dye, DYE, which contains iodine. If your patients are allergic to iodine, when they get the radiopaque dye, DYE, they will try to dye DIE. We would like to avoid that. MRIs. So MRI, different type of radiation. Where we have X-rays and CT, it's an ionizing type radiation. MRI is magnetics. Pulmonary function tests, great things, spirometry at the bedside, which is different than the incentive spirometer, which you're learning to use or will be learning to use in lab. The bedside spirometry is giving an accurate measurement of the tidal volumes. An incentive spirometer is not an accurate measure, but it does give us a window into how the patient's respiratory system is performing as far as moving air. Skin tests. PPD, tuberculin test. Wait, that's a test for a respiratory disorder? Why, yes, Sean, yes it is. PPD, the test that we use for TB, though it is being supplanted in many areas with the blood test quantiferin gold, tests the body's immune system's response to this purified protein from tuberculin. And this localized reaction to that PPD indicates that you have been exposed and may possibly have tuberculosis. And then the next step is the quantiferin gold or the chest x-ray. Other blood tests that you may see would be white blood cell count if we're suspecting infection or respiratory infection, the ABGs, and various markers for inflammation. So what do you think? True or false? Spirometer used interchangeably with the incentive spirometer. If you answered false, you would be correct, because we just talked about that. All right, incentive spirometer also measures pulmonary function in a sense, but it is not, it's not really diagnostic. And one of the main reasons I love the incentive spirometer, it is the greatest piece of equipment that we give all of our patients and they totally forget how to use. The idea with the incentive spirometer is you are to breathe in through it, keeping the ball in between these marks and bringing the piston up to a certain point. That's showing how the lungs are, or the airways and the lungs are performing to draw air. But also what it does is it forces the patient to breathe deeply, which then inflates the lungs fully and prevents atelectasis. And it can also make them cough, which is good because you want to move the mucus out so that they do not develop pneumonia. And the last piece is, think of your lungs as a big radiator. So you've got an internal body temperature of 98.6 degrees-ish. Some run a little hotter, some run a little colder. That's an average. I have seen and used the incentive spirometer to actually lower the body temperature a small bit. Very low-grade fever. How does this work? You are drawing in cooler room air and exchanging that with that hot body air, blowing that out, and you are fully inflating the lungs, bringing all that air in, and it does work to lower core temperature slightly. It's not going to take you from malignant hyperthermia to normal, but it's another tool in the kit. Postural drainage. Postural drainage. This is adjusting the patient's position to help drain the respiratory system. Also, chest physiotherapy. There are various ways of doing this, and even some pieces of equipment that cause vibration to the chest, which helps to loosen up mucus and get it to move. And then last but not least, inhalation therapies. So what would an inhalation therapy be? How about an inhaler, a corticosteroid, or a bronchodilator? Inhaled to open up the airways and help restore respiratory function. Common surgical treatments: thoracentesis and paracentesis. All right, let's hold there for a second. So centesis here, drawing off fluid. So thoracentesis from the thorax, paracentesis from the abdomen. Both of them may be used to ease breathing. Okay, so the thoracentesis makes sense, right? If you have fluid taking up space where the lung wants to be, the lung can expand to where it should, and therefore if you draw that fluid off, the lung has a place to expand to. Makes sense. Paracentesis, draining fluid from the abdomen to help ease breathing. Think about this. You have this, we'll call this thorax, this is the rib cage. Right down here at the bottom, sealing that off, is the diaphragm, which flattens and domes in rhythm to allow you to breathe. As it flattens, it tries to create negative pressure as it's flattening out, and the atmospheric air pushes in through your airways to inflate the lungs. Nature abhors a vacuum. Does this make sense? And then when it domes, then it's increasing the pressure in the thorax above what the atmospheric pressure is, and you breathe out. But that action, it has to have some place to go when it's flattening out. So if the abdomen is overloaded with fluid, you may see this in liver failure patients. They develop what is called ascites, and that excess fluid puts pressure and does not allow the diaphragm to flatten completely. So we tap that fluid off. There's more room now, and the diaphragm can flatten completely, and the patient can breathe in fully. This is one of the same reasons, not for the fluid, but for the pressure on the diaphragm, that your bariatric patients, bariatric may be a new word for you, your very obese, morbidly obese patients, your really heavy patients who cannot sleep lying down, or they can't tolerate lying flat for very long because they can't breathe. When your patient is up there in weight and they lay flat, all of that weight flattens out and ends up pushing on the diaphragm. Your patient struggles to breathe. So this is why your bariatric patients very often sleep sitting up. Next, thoracotomy. So thorax, and an otomy, or cutting into. Note remember there's a difference between an otomy and an ectomy. Draw that back into med term there. An otomy, cutting into. An ectomy, cutting it out. All right, does that make sense? With a thoracotomy, now this is up here. Well, let me tip this down a little bit. This is a semi-closed system. your chest. You have ribs to keep the shape. You have muscles that pull the ribs up and apart when you breathe in, as well as a diaphragm that flattens out to try to create this negative space in here. You have a patent airway for air to travel in and out. Now, this is all about pressure. When you breathe out, everything collapses down and up, creating a pressure that's higher than the pressure of the atmosphere around you. Air moves out. When you breathe in, diaphragm flattens, okay, which is trying to create a vacuum inside this closed space because you've got ribs that are keeping everything from collapsing. If you didn't have ribs, when your diaphragm flattened down, the air pressure would just push things in and you would have no movement through the airway, right? Makes sense? So when you breathe in, rib cage opens up, diaphragm flattens, tries to create a vacuum. Nature abhors a vacuum. You have a patent airway. Atmospheric air pushes in, down into the lungs, and the lungs expand to fill the space that's being opened up by the expansion of the rib cage and the flattening of the diaphragm. A closed-ish system. If it was a completely closed system, you wouldn't have an airway, and that would be bad. But you only have one pathway in and out. So what happens in a thoracotomy? We are cutting into that closed system, right? Opening it up. A prime example would be open heart surgery, where you're splitting the sternum in half, jacking everything open, redoing the plumbing. Well, when that is open, you don't have the air pressure differences. When you put it back together, until all the leaks have healed, your patient may require not only ventilation, because a ventilator doesn't rely on that atmospheric pressure pushing in and out. It pushes in, lets out, pushes in, pushes the air in, and lets it out. With a patient with a thoracotomy, if there is a leak, or if the patient receives a puncture to one side or the other, that atmospheric air can push in through that hole or through that incision and compromise the patient's ability to breathe, because it's no longer being able to try to create that negative pressure. When it does create that negative pressure, it not only draws it in through the mouth, but it draws it in through the hole or the surgical site. So for that, we would use chest suction or a closed seal drainage system, which in the chest suction is just that. It's suction hooked up to the chest. Or the closed seal drainage systems, which may have suction connected to them, which when the patient breathes in, it allows fluid and trapped air in that space to have a place to get out, but then it has a water seal that doesn't allow that air fluid back in through the tube, which then keeps the thorax closed up, and the patient is able to breathe. Their lungs can inflate and deflate. Right? Nursing implications for a thoracotomy. Okay, well, there are the usual, right? Let's see if we can all remember here. So, thoracotomy is a surgery, right? So you have pain, potential for hemorrhage, both internally and externally, potential for infection, okay, inflammation, and finally, anesthesia complications. A surgery is a surgery is a surgery. The difference is where it is, where the surgery is happening. With the thoracotomy, one of the big nursing implications or nursing things to keep in mind is with your closed seal drainage system. They generally come with hooks, and they also come with a little flat stand that they can sit on the ground. Do not, if they have hooks and you have a place to hook it there. Because if you punt the drainage system, you can measure the drainage in the drainage system, but once you tip it over, not only do you have to reset the water seal, but you also have to now mark all of the areas so that you can keep an eye on drainage. And that can become rather interesting. So what do you think? True or false? From the reading, during a paracentesis or a thoracentesis, must take the blood pressure and pulse immediately after the procedure and every 15 minutes until readings are stable. What do you think? True or false? Sounds reasonable, right? It is true. Okay. So let's talk the pathophysiology on this answer. So if we withdraw a large amount of fluid from the thorax or from the abdomen, okay, then here's the heart. Coming off the top of the heart is a great big blood vessel called the aorta. It is a big, high pressure, high volume hose. On the venous side, returning to the heart, is the inferior and superior vena cava, very large veins. Okay. So here it says hypovolemia, and that is both accurate and inaccurate. So the blood volume does not change when you remove that large amount of fluid. The blood volume doesn't change, but you have these two big pipes. I'll put them like this. Yeah, there we go. So we've got these two big pipes. When there is all the excess fluid on board, those pipes are constricted. Okay, that makes sense, because you have all this excess fluid and excess pressure around the pipes. Now, when we remove that fluid, the pipes can expand out a bit again. What does this have to do with blood volume? So when the pipes are constricted, let's take my Mountain Dew bottle here. Okay, so here is my inferior vena cava or my aorta. As the pipes are constricted, you see how that volume goes up, right? Now, I tap off the fluid, and you can see how the volume goes down. That decreases the pressure. The volume in this bottle has not changed, but the amount of space available has increased. Therefore, it's a smaller volume for the size of the container. I hope I haven't just confused the crap out of you on that one. Okay. So it decreases circulating blood volume, which then decreases the blood pressure. Well, I mean, it decreases the pressure. The volume remains the same, but the pipes are bigger, so the pressure is lower. Well, but lower blood pressure, isn't that the best thing? Isn't that what everybody is, all the doctors are saying? Yeah, you got to lower your blood pressure. You got to eat right. You got to avoid salt. You got to quit smoking, Sean. Yes, they are saying that, but your blood pressure can get too low. All right. And if your blood pressure is not low enough, when you are standing, your heart is working against gravity. Your brain needs blood. It needs oxygen, needs glucose, needs those two things to keep functioning. When you're working against gravity, that pressure, gravity is pulling down, the heart is pushing up, the pressure is low, not as much flow gets to the brain, not as much pressure gets to the brain, and you can experience syncope. Everybody probably has experienced this at least once or twice, where you've been sitting for a long time, and you stand up too fast, and okay, you get woozy. Sometimes pass out and fall, right? That would be syncope. The next piece, shock. Okay, Here's another one of those, write it down. Shock is a big drop in blood pressure. Shock is shock. If you go into shock because you ruptured your femoral artery and you're bleeding out on the ground and now you're hypovolemic, you go into shock there because you really have a reduction in your circulating blood volume, hypovolemia or low volume. That's hypovolemic shock. Blood pressure drops. If you are allergic to peanuts and chow down on some General Tso's chicken, okay, and you have the bad, nasty anaphylactic reaction, and then your blood pressure tanks from the vasodilation, that's anaphylactic shock. A big drop in the blood pressure. So shock is shock, right? So directly after the procedure, be it a paracentesis or a thoracentesis, and at least every 15 minutes, and that just means that's here every 15 minutes. Yeah, okay, that's the standard. But if you see the patient and they really make you nervous, you could take it much more frequently than that. But at least every 15 minutes until the readings are stable and within, say, acceptable levels, within a normal level. So the last piece before we go on to this, when we're talking about a big, removal of a large amount of fluid, right? This can be done by nurses not wielding needles. So, patient has urinary retention. We place a Foley catheter, a urinary catheter, and we immediately get a liter of fluid off, a liter of urine, and it's still flowing. What do? Well, if we don't want our patient to become hypotensive, we clamp that catheter and give the patient a little time to adjust. Because in the abdomen, taking up space with those two big pipes that run down through there is the urinary bladder, which can often hold a very large amount of fluid. And when it holds a large amount of fluid, it's taking up extra space. It's putting pressure on the other abdominal organs and the vasculature. When you tap that off really fast, then that bladder shrinks, those vessels expand, patient's blood pressure goes. It actually makes that sound. So with that, when placing a Foley catheter as a nurse, you want to be very cognizant as to how much is coming out, because you can put the patient into shock by taking off too much fluid. So not just with a needle, but sometimes with a catheter. So what do we think? Perfectly safe for a client with a respiratory system disorder to receive a narcotic. Well, I mean, we give a lot of narcotics, right? I mean, that has created quite a problem in some parts of the U.S. Perfectly safe. What do you think? No. Now, it may be safe because patients with respiratory diseases get narcotics all the time, often for chronic pain issues or other things going on, but it's not perfectly safe. Central nervous system depression experienced with narcotics can create respiratory depression, because where's your respiratory triggers coming from? Central nervous system. Okay. Lowers the respiratory rate. Okay, well, big deal. They're not up and moving around, except that not only are they not bringing as much oxygen in as they would normally do, but they're not getting rid of the CO2. It causes hypoventilation. Hypoventilation, the risk is not only not getting enough oxygen, but retaining CO2 and becoming acidic. Most dangerous for those whose respiratory function is already compromised? Yes. Can a person who has perfect health, or at least really good health, still experience respiratory depression? Yes, that is heroin overdose. It doesn't stop the heart, I mean, at first, but it does depress the respiratory drive, or can stop the respiratory drive. And, well, okay, that's B. If you don't have A, B and C don't matter. If you got A but you don't have B, C becomes relevant eventually, right? So, nursing process. Oh, yay. Remember, and pi. I even wrote it backwards on a board. All right, and pi. Assess, nursing diagnosis, plan, implement, evaluate. I love pi, right? And which is kind of handy. All right, so alterations in respiratory status. Aspiration, was the patient eating or drinking and then suddenly start coughing? Hyperventilation. Oh wait, hyperventilation? Okay, so here's the piece. Hypoventilation. We'll start with hypoventilation. Not bringing as much oxygen in, not blowing off as much CO2. CO2 builds up in the body, the pH drops, comes out of that narrow range that we exist in, 7.35 to 7.45. The pH drops, right? Right, because you're becoming acidic with hypoventilation. Hyperventilation. Respiratory rates too fast, bringing in lots of oxygen, but also blowing off too much CO2. Okay, CO2 level in the blood drops. The patient becomes alkaline or alkalotic. Right? Flip sides of the coin. Too slow, respiratory rate too low, you're looking at the potential for acidosis. Respiratory rate too high, you're looking at the potential for alkalosis. Either way, you are looking at a risk to the patient. Hypoxia. All right, a couple of different, hypoxia, hypoxia, right? Low oxygen, right? Hypoxemia, condition of low oxygen in the blood. Okay, so hypoxia, right? Circulation hypoxia. So tissues can experience hypoxia because the cardiovascular system is not delivering sufficient oxygenated blood to that area. Right? Anemic hypoxia. Okay, so anemia. Lack, or not lack of, but a decrease in the number of red blood cells. Okay, decrease in the number of red blood cells. Well, what is a red blood cell's job? Red blood cell's job is to pick up oxygen, drop off CO2 in the lungs, drop off oxygen, and pick up CO2 in the tissues. Okay, you've got enough red blood cells and a good functioning respiratory system, life is grand. If you have a good functioning respiratory system, but you don't have enough red blood cells, you are not transporting away as much oxygen, or not transporting to the tissues as much oxygen, and you're not returning to the lungs as much CO2. And then histotoxic, where you have tissue damage or death that is causing a hypoxic state there. All right, so planning and implementation, because it doesn't, a plan's not all that effective unless it's put into use, right? So, relieving respiratory distress, orthopnic positioning the patient so they can breathe easier, right? Turning, coughing, and deep breathing. Again, especially in surgical patients or in medical patients who are normally active but are now sick in the hospital. Turning helps to mobilize secretions so that they can cough them out. We don't want the secretions building up in the lungs. Secretions, mucus, lovely nutrient-rich beds for bacteria to inhabit and grow in and throw a big party. And a bacterial party in the lungs, we call that pneumonia. Okay. Deep breathing, forcing the patient to open their lungs up fully, providing maximum real estate for gas exchange, right? Oxygen for CO2 in the lungs. If you're not breathing deeply, if you're not getting those open all the way, the air is not reaching as much of the lungs as it could, and you're not expelling as much CO2 or getting as much O2 in. And you also don't have that movement to help mobilize the secretions so that they don't build up. Okay. Respiratory treatments, postural drainage, again, this, positioning the patient. Breathing exercises, and as simple as, okay, Bob, I want you to take 5 nice deep breaths for me, in through your nose and out through your mouth, or utilizing the incentive spirometer. Perhaps as well as respiratory, because the incentive spirometer is considered a respiratory treatment. Also, you have the medical treatments or the medication treatments, the breathing treatments, nebulizers or inhalers, right? Or administering oxygen for the patient who is, either temporarily or permanently unable to get as much oxygen into their bloodstream as they require. So then we increase the amount of oxygen that they're getting so it can maximize the amount of oxygen reaching the tissues. Make sense? Right? Nasal treatments. Now, some of you may not know what it's like to go through the life with a beak like this. Allergy season sucks, okay? But nasal treatments, because there's a lot of tissue up here that air needs to pass through, and when that is inflamed or reacting to pollen, there's not a whole lot of airflow going through there. Oral or nasal or pulmonary secretion suctioning, right? 2 things. Virtual foot stomp there. You may see this again. Desaturation and dysrhythmias. So desaturation, decreasing the amount of oxygen in the bloodstream, which makes sense, right? If you are sucking the air out faster than the patient can get it in, your oxygen levels are going to drop. And dysrhythmias, from different causes related to this, but alterations in cardiac rhythm related to suctioning and irritation. Right? And our last piece of the nursing process, yay, evaluation, which brings us right, okay, did it work? And then we're assessing again. Okay, did it work? Was it effective? Did this need to change? Right? Back to evaluation, assessment, nursing diagnosis, plan, implement, evaluate in that big circle that goes on and on and on and on and on till the patient discharges or dies. So, little terminology here. I'm going to touch on the high points for this. Right? Dyspnea, difficulty breathing. Orthopnea, difficulty breathing in a position. Okay. Tachypnea, fast respiratory rate. Hyperpnea, really fast respiratory rate. And bradypnea, or low respiratory rate. So tachy, brady. Tachy too fast, brady too slow. Back to your medical terminology. Hypoventilation and hyperventilation. Now, hypoventilation may not just refer to the rate at which you're breathing. Right? It may refer to the depth at which you're breathing, because a person could be breathing at 20 breaths a minute and still be hypoventilating if their breaths are very shallow. And that's the second time I've had a lecture interrupted by a strange cat sound. Oh, COVID-19, I love you. The next pieces that I really want to look at, you can review Cheyne-Stokes and Bios in the book, okay, and Kussmaul's. Apnea, all right? Sleep apnea, central apnea, obstructive apnea, all right? So central apnea, this is a control piece, all right? Central CNS, right? Apnea, not breathing. That not breathing, that's a problem. A, B, C, right there, second one down the line. So with central apnea, this is a control piece. This is a neurologic control. Obstructive apnea, something is blocking the airway. And then you have sleep apnea, where the patient stops breathing in their sleep and then gasps up, which can be as a result of central apnea or obstructive apnea. Very often you will find your patients, especially those who are overweight into obese, who develop obstructive sleep apnea, where positions and sleeping and their body shape all come together to obstruct the airway so that the patient can't breathe normally. And very often you will find these are patients that do not sleep well whatsoever, and they end up waking up multiple times a night, waking themselves up because they just can't breathe. Very common, becoming more common in our patient populations. So, infectious respiratory diseases. Common cold or acute rhinitis, right? Often caused by a coronavirus. Not the COVID, the SARS-CoV-2 that we're currently dealing with, but often from a coronavirus, right? Common cold, upper respiratory generally. Acute rhinitis, so like runny nose, right? Or, would actually be rhinorrhea, rhinitis, inflamed tissues in the nose, which can block part of the airway and causes that difficulty breathing for some people. Strep throat, flu, influenza. Now, I'm going to go on a little bit of a soapbox here, a very small soapbox, because I can't move much and not get out of the camera. Get your flu shot. Just get your flu shot. When we made this flop to distance ed over the weekend, some dummy had not gotten his flu shot yet. Some dummy came down with influenza A in the middle of the flop. All right, get your flu shot. But Sean, whenever I get my flu shot, I get sick. I get the flu. Okay. I'm going to call you on that one. It wasn't the flu shot likely that did it to you. If you did actually get the flu, consider where you got the flu shot. Not which muscle group you got it in, but where did you get it? Very often, especially in healthcare facilities, you have employee health, which is somewhat of an afterthought. And they're stuck in a broom closet somewhere down in the basement. And when I mean a broom closet, I mean that generally not much bigger, where the employee health nurse sits and gives all the flu shots, does all the mask fittings. Come flu season, everybody goes to employee health to get their flu shot because it's free. Meaning everybody who has already been exposed to the flu and doesn't know it is going through this one little room, and it becomes ground zero for a flu outbreak. That is one piece. Or, well, tell me about, so you got the flu shot and then you got the flu. Describe your symptoms. Well, I just felt crappy for like 3 days. Okay, kid, you didn't get the flu. Congratulations, you had an immune response to the flu vaccine, which is exactly what it's supposed to do. Charge your immune system so when you're actually exposed to the particular strain that's going through, that it's already prepared to fight it. There is a lot of difference between that couple of days of malaise and just not feeling good and the honest to God flu. The honest to God flu can kill you and does kill thousands of people every year in the US. End of soapbox. Get your flu shot. And the SARS-CoV shot when it finally becomes available, because we haven't seen the last of this. Laryngitis, right? Inflammation of the larynx. Inflammation, voice box, larynx, difficulty speaking, vocal cords become inflamed and they don't vibrate really well. Right? Bronchitis, inflammation of the bronchi. Okay, itis, inflammation, right? Inflammation of the bronchi. So here I got this tube. Let's say, we're just going to take a cross section here. Got this tube. All the air is flowing through that, in and out, in and out. And if that tube stays at its normal size, life is grand. Air moves in, air moves out. That's good. And then you get inflammation of the bronchi. And that inflammation takes up space. Now, what has happened to the size of that tube? Less air is able to move in and out. Last piece, lung abscess. So what is an abscess? An abscess, a collection of fluid, pus, right? This is one in or around the lung. So you have pus production, which generally means infection. You have an abscess, and that is going to impair that piece of the lung's ability to expand and exchange oxygen for CO2. Right? Main job there. Pneumonia. Okay. And I swear I have fixed this slide so many times, and this keeps coming back. So, bacterial pneumonia. Right? Bacteria get into the lungs, party. They create pus, they create nastiness. Bacterial pneumonia, bacterial cause. Wow, almost like it's in the name. Viral pneumonia. I wonder what causes that. Right? PCP, not angel dust. Nope. Pneumocystis carnii, which is not actually an accurate term. In rats, it is PCP. In humans, it's PJP, Pneumocystis jirovecii pneumonia. In the early days of HIV, it was noted that these patients who had developed AIDS would come down with this pneumonia, and in tests on rats, giving rats AIDS, seems so rough on the rat, really bad on the human, that they would develop this bacterial pneumonia, and it was Pneumocystis carnii. So that was transferred over to humans. Well, actually in humans, it's PJP instead of PCP. Chemical pneumonia, burns and inflammation from chemical inhalants, causing fluid to build up in the lungs and cause pneumonia. And then last but not least, the mealtime friend, aspiration pneumonia. You've aspirated food and oral contents into the lungs, and as we were talking about earlier, hopefully you don't have the same bacteria growing in your lungs that are growing in your mouth. Well, now you do, or now your patient does, and the lungs don't tolerate bacterial colonization well. And so they develop pneumonia from aspiration. Pleurisy or pleuritic chest pain. Histoplasmosis, another respiratory infection that pregnant women and immunocompromised are at an increased risk from. And where might a person contract histoplasmosis? Cat lovers, feel free to chime in. Tuberculosis, TB, at this point, the last disease that you can actually be involuntarily committed for. Well, I mean, sort of COVID-19, I mean, we're all sort of involuntarily committed to our homes, stay-at-home orders. But tuberculosis used to be endemic in the United States, is still endemic in some parts of the world, meaning it is common in the populations. Hence, have you traveled outside of the country? Certain medications that may depress the immune system, they want to know your travel history before starting on these medications, because TB is still endemic in certain parts of the country. So here's a quick question for you. State hospital. All right, we all know the state hospital here. That's also known as the hoo-hoo room. The nuthatch, whatever your favorite name for it is, was not always just for the insane, but also for treatment of tuberculosis cases. Sanatoriums or sanitariums, I find the term used universally when talking about TB hospitals. These were places where people would be sent to recover or die from tuberculosis. Right? So we have a difference between latent and active TB. Latent TB, the infection is there, is not currently causing symptoms. Active TB had those symptoms and an increased ability to spread. Now, could a person with latent TB spread tuberculosis? You bet. But with active TB, it spreads much easier. Pulmonary tuberculosis, because you can have tuberculosis in other tissues than just the lungs. Okay. POTS, you can review those. Multi-drug resistant TB. I want to talk about that because this is scary. So tuberculosis is already very difficult to treat. The course of treatment for tuberculosis can range from 3 months for post-exposure prophylaxis to 2 years if retreatment is necessary, with a combination of medications that really can make the patient feel like junk. That's the best way. I mean, just they are not very fun for the patient to take. And that's with a non-drug resistant TB. Now, when you start talking about multi-drug resistant tuberculosis, it gets a lot scarier because now this is tuberculosis that is resistant to many of the, more than one of the medications used to treat it. Makes it much harder both to treat the patient, to get rid of the TB. Also makes it much harder on the patient because the treatment may last longer or use medications that are even harsher for the patient. This would normally be the time I would jump upon my soapbox about antibiotic resistance and don't overuse or misuse antibiotics because we don't need any more superbugs. In the case of tuberculosis, we are already finding multi-drug resistant strains And this could end up being a game changer as far as tuberculosis goes. Empyema, pus in the lungs, actually pus in the thoracic space. Now, if you have pus collecting outside the lung, down there, you're taking up space that the lung would normally expand into. Plus, okay, there's something going on that you're producing pus, also not a good sign. That would be an acute empyema. There are patients with chronic empyemas that the pus accumulation may be drained off, but it keeps returning, and it doesn't respond in a permanent way to treatment. Okay, what do you think? Look at my face and see and recall how much of a concern I have for tuberculosis. What do you think? Decreased dramatically? Whoop. Helps if I hit the right button. No, has increased dramatically. Mainly due to multi-drug resistant TB organisms. HIV infection also lowers the risk or lowers the ability of the body to fight it off and then develop an infection. Substance abuse and homelessness. The hell does that create an increase in TB infections? Okay, so homeless population. Sometimes living in shelters, sometimes sheltering in odd places, huddled together under bridges in close proximity. One person has it, breathing, coughing, being around these other people who, being homeless. There's a high instance of substance abuse, which physically can affect your ability to resist disease, right? Mental health issues in the homeless population, substance abuse, mental health issues, pretty high in those populations. So here they all are. And now you have a patient or a person with tuberculosis huddled in with that mass, and it spreads. Okay. Poor compliance with medication treatment plans. This is where you start reading about DOT. Who's DOT? Directly observed therapy. Recall I said these medications are not pleasant. Okay. Patients with tuberculosis may decide that they just really don't like it, and they don't take the medication. They don't follow through with the treatment regimen, and they may be ordered to have directly observed therapy, where they go to a clinic once a day, or somebody comes to their house once a day to directly observe and watch them take their medication. Because the next step could be involuntary admission to a hospital, probably a state hospital, for the course of 9 months to 2 years, depending, so that they take their medications to get rid of the TB, because tuberculosis is a public health risk. Yeah, you can still get involuntarily committed for presenting a public health risk. Another thing that might tie into poor compliance with medication treatment plans. Go back 1 comma, back to homelessness, back to the homeless populations. All right, if you can't afford the medications, it may be provided for you, maybe not. If you don't have an address, directly observed therapy may be a problem, right? And mental health issues. So all of these can also lead to poor compliance with the medication treatment plan, for the medication regimen, which can complicate treatment or render treatment ineffective. Hence, increasing cases of tuberculosis. and increasing numbers of multi-drug resistant tuberculosis. Because if you only half treat a disease, right, which is why my soapbox for the improper use of antibiotics. And I am sure you've heard this before, and if you haven't, well, you're hearing it now. What doesn't kill you makes you stronger. In the case of bacteria, and in this case mycobacteria, means that half of a treatment regimen will knock off the weaker bacteria, leaving those that are stronger or are beginning to develop some resistance to reproduce. And then what happens when they reproduce? They're reproducing the resistant bacteria. So counsel your patients, a lot of good patient teaching. I know that Keflex makes everything taste yucky, but if you are told you need to take it for 10 days, 3 tablets a day for 10 days, you take 3 tablets a day for 10 days. You don't stop taking it when you're starting to feel better, because you've only killed off the weak ones and left the strong to reproduce. All right, chronic respiratory disorders. Yes, snoring is a chronic respiratory disorder, which may tie into sleep apnea. Allergic rhinitis. Now, not acute rhinitis, but allergic rhinitis. Every year, the flowers bloom, the nose stuffs up. That's a chronic respiratory disorder. Pneumoconiosis, COPD. That's a very common condition in the hospitalized or institutionalized population. And these can, now COPD is a blanket term. So it can be as simple as bronchial asthma, bronchiectasis, chronic bronchitis, or emphysema. Right? So COPD is not just one diagnosis, but a blanket term for many. And then to draw us back into COVID land, acute respiratory distress syndrome, which some patients with the COVID-19 infection, the SARS-CoV-2 they experience acute respiratory distress syndrome. So let's break that down. Acute, right? Sudden, respiratory, respirations, distress, and okay, it's in the name there, syndrome. So it's a grouping of symptoms. Also known as ARDS, ARDS. Acute respiratory distress syndrome can be brought on by a number of things, including chemical exposures. ARDS is not a chronic respiratory disorder, by the way, because it's in the name there. I'm not sure what happened with that, but yes, ARDS is not chronic. So, true or false? CPAP. Speaking of our sleep apnea patients, continuous positive airway pressure, right? It's commonly used to treat people or to assist people with allergies. How do you think? Yeah, no, right? With sleep apnea, it delivers air at a higher than atmospheric pressure, okay, at a continuous pressure to help force the air in and keep the lungs expanded. The patient can breathe in really easy. They have more of an effort to breathe out. It says it reduces the breathing effort. It reduces the inhalation effort. Okay. The other side to that, well, not really side to that coin, but the other piece to that is called BiPAP, bilevel positive airway pressure, which as the patient breathes in, it pushes at a higher pressure, and at the end of the inhalation cycle, when the patient breathes back out, it lowers. It's still providing pressure higher than atmospheric pressure, but it's a lower pressure so that the patient can breathe out easier. And these are not something that you just go buy off a Craigslist and set it up because, yeah, man, I've got sleep apnea, and who wants to go to one of those sleep study things? Because you can do a fair amount of damage with improper settings on the CPAP. Those settings are designed, then they're individualized to the patient. So if you were thinking of doing that, don't. Go see the sleep specialist. All right. Trauma. A little familiar with trauma. Had one or two in my life. So an absence of air exchange. All right. If you've got no air exchange due to trauma, right, it could be A or it could be B. Either way you look at it, C not really mattering at that point, right? Air is either not moving or it's not exchanging in the lungs. More than likely with trauma, air is not moving, possibly due to pressure, possibly due to obstruction, but you have an absence of air exchange. Chest trauma, recall that, you've got, even if the chest trauma does not provide a penetrating injury or break a rib and penetrate something inside, remember that your rib cage is there to help work against atmospheric pressure, so that when you breathe in, you're trying to create that negative space inside there, and atmospheric pressure pushes the air in through your mouth and nose and down your airway into the lungs. Chest trauma can, one, make the patient not want to breathe that deeply. If anyone has ever broken a rib, you know that deep breathing does not feel real fun. If you have broken a rib, or if you have not broken a rib, perhaps you have coughed so hard when you were sick with the flu or something that you've stressed the muscles and it hurt to breathe in deeply. This is something that, especially open heart nurses or post-open heart nurses, we do to our patients. And it's sort of evil, but it is necessary. So when I talked earlier about a thoracotomy, an open heart surgery, split the sternum, jack everything apart, fix the plumbing, drill some holes on each side of the sternum, and then wire it back together, bang the ends of the wire down, because that's really what's happening. Okay, it's like it's sterile baling wire, right? Stitch everything together, put some chest tubes in, send them on to recovery. They spend a night in ICU, and then they get extubated, and then they move to the step-down unit. And the first thing the step-down unit nurse does says, "Okay, Bob, I want you to take 5 really good deep breaths and then cough for me." And Bob takes one really deep breath and then goes, no, that hurts. Chest trauma, he's going to hypoventilate because he has had, it's surgery. The difference between surgery and trauma is intention. So pain can do that. Respiratory complications and drug poisoning, like overdose, like opiate overdose or narcotic overdose, depressing the central nervous system. Okay. Drowning or near drowning. There is a saying in medicine, especially in pre-hospital care and emergency care, that you are not dead until you're warm and dead. Okay? So how does this play into drowning or near drowning? Cold water versus warm water drownings. Cold water drownings actually have a greater chance of recovery than warm water drownings. Okay. Remember I said that we exist in a fairly narrow range of temperature and pH, yes? Too cold, things slow down. Too hot, and the enzymes and the proteins denature and they lose their function. Cold water drowning, everything slows down. That's actually what your refrigerator is doing right now for your cheese, keeping the mold from growing. The mold's still on the cheese, it's just not growing because the temperature is so cold that its metabolic rate has slowed down. When hypothermia is induced, say in a cold water drowning, cellular activity slows. So the two patients, one drowns in 32-degree water, one drowns in 80-degree water. They're both down the same amount of time. They're both rescued at the same amount of time, or at the same time. Warm water doesn't survive, cold water does. Because in warm water, there's nothing to slow down that metabolic rate. The tissues start for oxygen and trying to continue their normal function, broke down. Cold water, tissues, while they were still trying to continue their normal function, they were doing it much slower because of the temperature, not as much damage done. Does that make sense? And then with trauma, oh, another fun one, pneumothorax. So remember I was talking earlier about you have this atmospheric pressure pushing on you at all times. And normally its only place to get in is through the airway, right, through your upper airway, down to your lower airway, and inflate the lungs, which is great. This is a semi-sealed system here, unless a hole develops. So say there's a hole that goes from outside of the chest wall to in next to the lung. Atmospheric pressure pushing in. Air moves in not only through here, but through that hole in the chest. There is no negative pressure anymore, that air builds up, okay? Or there's a weak spot in the lung tissue. Patient coughs, something happens, pops a hole in the lung. Okay, well, the lung is not stuck to the chest wall. So air is being pushed in as it normally would, but it is coming into the lung and then out through that little hole into the thoracic cavity. There you have a pneumothorax, where you have air collecting in the thorax. Another piece of that would be a hemothorax. All right, if pneumo's air, what's hemo? Blood. Blood collection in the thorax. Same basic effect is now the blood is taking up real estate that the lung really wants to expand into if it's going to do its job, and causes that collapse. And then the hemopneumo, where there is, well, weirdly enough, in the name, blood and air collecting in the thorax. Right? Neoplasms. There's another one to add to your toolkit for words. Neoplasms. So new growth. We're looking at tumors here, really. You see, I have it broken down into benign neoplasms and lung cancer. Well, okay, everybody knows lung cancer, right? That's scary. But a benign, doesn't benign mean good, or at least not bad? So benign may not be cancerous. It can turn that way, but it may not be cancerous. But that does not mean that it cannot cause issues for the patient, because this is a tumor, this is a lump of cells that is growing here that is abnormal, and depending on location, can cause dysfunction. Say, let's take my bronchi here, all right? And I develop a benign neoplasm inside that bronchi. Okay, and it grows a little bit. What has happened to the amount of airflow through that bronchi, or through that bronchus? Airflow has been decreased. The tumor is not cancerous, but it can still cause problems. the nose, right? Sinusitis, right? Inflammatory disorders. So if it's inflammation, it's an itis, right? So inflammation of the sinuses. You can have acute and chronic. Acute may be a condition where you got a face full of the wrong kind of pollen. You got inflammation. Chronic, it could be a more chronic allergy or an immune condition. So inflammation, I mean, yeah, okay, it's inflammation inside the tissues in the nose, makes air passage difficult. Let's look at structural disorders. Deviated septum. So review the biology there. You know, septum coming down, if that's deviated to one side or the other, can affect air passage. Right? Nasal polyps, little berries, if you will, growing inside the nose. Right? Structural disorder can be fixed by or caused by plastic surgery or rhinoplasty. Okay. The last piece, care of the client undergoing nasal surgery. All right. So a surgery is a surgery is a surgery is a surgery, right? Pain. Okay. All right. Pain, face hurts. Okay. That may or may not affect your willingness to breathe deeply, but you know, pain. Inflammation. Yes, you know, you're going to have inflammation in the face and potentially some hemorrhage. Okay. Now here's the tricky bit. Hemorrhage may show up and it may be the bruising because a patient undergoing rhinoplasty, I'm going to go in and get my beak fixed, come out looking like directly after surgery, looking like they've just done 10 rounds with Tyson, because surgery is not a gentle process, just in case you were wondering. There, especially anything that involves bone, there's generally a lot of chipping, hammering, and bending and breaking pieces off. Right? So a patient undergoing rhinoplasty, I mean, they may look like they've been beaten when they're done, because there's the inflammation, there's the hemorrhage. But that's not the hemorrhage we're totally worried about. Because of its location, bleeding can be rather sneaky, and it can go right down the nasopharynx, down through the oropharynx, down into, well, the lungs or the stomach. Now, your stomach can hold a whole lot of blood before you find out. And in that case, I mean, a patient can bleed, can have a pretty spectacular bleed going on or have a large loss of blood and not being really noticed until they're vomiting bright red blood. So hemorrhage is there. Anesthesia complications, again, are there. Surgery is a surgery is a surgery is a surgery, right? Nasal trauma. Well, okay, nasal fractures, broken nose, epistaxis, your new favorite word, all right? Epistaxis. Simply, it's a nosebleed, okay? That's the word you want to use, you know, with your family to make them think that you've really got something crazy going on. I've got epistaxis. Is it fatal? Not if I, you know, pinch it off. And all right. Throat disorders. Again, airway. If you don't have A, B, and C, don't matter. So trauma. Right. Well, trauma directly to the throat can cause inflammation, but also aspiration of foreign bodies, choking. Okay. Cancers. So laryngeal cancer takes out the voice box. Communication. How is that patient going to continue, one, with their treatment, and two, with the rest of their lives? Communication is going to be an issue. That's when you hear the guy with the box. He's talking through. He sounds like a McDonald's drive-through. Okay, or at least an old one. So there are tools that can be used for the patient to still be able to communicate. And it may go into in the near term where you are communicating through writing boards. Right? Identification as a laryngectomy. Well, why would that be a problem? Well, a number of things. You know, the one that always comes to mind is, you know, guys pulled over and and the cop asks for license and registration, or have you been drinking? And you know, the patient doesn't say anything, and you know, gets hauled off to jail. That's no, but it's a visual there. But also, you know, you have some dangers as far as swallowing. And as far as medical treatments, that identification is going to be necessary. Supportive resources. The patient has lost their ability to communicate. The patient has perhaps lost their ability to eat the foods that they want to eat, depending on how much was damaged by the cancer. Patient may have lost their ability to eat solid foods whatsoever. And also, you have dangers with water. Especially if that patient also happens to have a percutaneous tracheostomy. I don't know if you've probably all seen the anti-smoking commercials, you know, where the guy's giving his tips, and it's like, and make sure you cover your trach when you take a shower. Okay, water dangers. A person can fall into a lake without a trach. A person can fall into a lake and not drown. A person with an open tracheostomy falls into a lake. They don't have the ability to close their mouths and not get the water in their lungs. Make sense? And that is it. Again, I do apologize. I do not know where that video went, but here it is now. I will upload this to YouTube and let you all know where it lives again. Ta.